Thank you so much, Jyoti. Good afternoon, everybody. Thank you so much, Dr. Anupama. Professor Kurgiliano, it was a pleasure listening to you. 2 consecutive weeks, it's a treat. And I'm so happy that you're going to stay back in this panel and you will, I'm sure, add a lot of value to what we will discuss in the next half an hour. So Jyoti has asked me to discuss uncommon clinical situations in breast cancer. There are so many, I just thought I'll pick up a few that we saw in the last couple of months. So we have Dr. Ashish, Dr. Sachin Hingmere, Dr. Randeep Singh, Dr. Bharat Bhosle, and Dr. Chinay, who is a pathologist who will join us because we are discussing some rare histologies also here. And of course, Professor Kurgiliano is also there with us. Without wasting any more time, let me get on to this. This is the 73-year-old lady with a left cancer breast. It's a locally advanced cancer, T4B, N1, and M0. I'm sorry, I don't have the photographs. So she has ER and PR that's negative and a HER2 that's 3+. She has chronic renal failure due to diabetes. Her creatinine is 3.4 and her creatinine clearance is 20 ml per minute, but she's not on dialysis. In fact, she has an AV fistula waiting to be dialyzed at any point in time. She has had a coronary artery disease, a bypass graft that was done 4 years ago. However, the 2D echo at this point in time does not show any regional wall motion abnormality, and her ejection fraction is 56. Okay, so 73-year-old locally advanced left-sided breast cancer, ER/PR negative, HER2 3+ with multiple comorbidities. Obviously, she will go for neoadjuvant therapy. So let me start by asking Ashish, what would you do as your neoadjuvant therapy of choice?
Yeah. So this is basically you're looking at a situation of chronic kidney disease and breast cancer, typically in an elderly patient. We are obviously looking at a neoadjuvant options here. So number one, trastuzumab. It is fairly safe to be used in deranged creatinine because it has very minimal renal excretion. So trastuzumab is something which I would use along with the taxanes. That is something which I would prefer. Now, in coming to the taxanes, as far as docetaxel and paclitaxel, both are there, very minimal renal excretion again. Docetaxel is actually completely safe. Paclitaxel has mild renal toxicity. So, but I will be comfortable using weekly paclitaxel with trastuzumab in this patient. And of course, monitor 2D echo very closely. I would not want to go for dual anti-HER2 in this case.
You would not want to go for any specific reason, Ashish? You don't want to do dual anti-HER2?
So, you are looking at post-CABG status with a little marginally compromised ejection fraction here. So we would want to, and we know that the dual anti-HER2 has slightly increased incidence of cardiotoxicity. So I would stick with weekly paclitaxel combination as a new
excellent weekly paclitaxel. Lovely choice, Bharat.
Yeah, so basically, this is an elderly patient with multiple comorbidities. So geriatric assessment has to be there to explain what the toxicity patient is going to face. And it is pretty obvious patient has cardiac comorbidities, diabetes, and CRM. So patient is anyways going to face the toxicities. And if I am not increasing the cardiac toxicity by avoiding anthracyclines, I would like to go ahead with using 2 drugs, because I know that using 2 HER2 anti-HER2 drugs, there are possibilities that chances of CR are more, so that in the consolidation I may reduce the further intervals, because I am facing a 73-year-old patient who, in spite of not having cancer, what is the survival, 5-year survival? That is also a question. So giving a good quality of life, with 2 anti-HER2 drugs and single agent paclitaxel, maybe look at the CR and then decide further treatment.
Okay, excellent. So dual anti-HER2 therapy. So paclitaxel seems to be a chemotherapy of choice, and then single or dual anti-HER2. Professor Kurgiliano, can I ask you, is there any way that you can avoid chemotherapy for this lady? We know that the PAT-CRs with dual anti-HER2 therapies are much lower compared to when you use chemotherapy plus anti-HER2 therapy. But would you have done something in this patient, some test in this patient to determine if there is a greater likelihood of responding and achieving a PAT-CR with just dual anti-HER2 therapy? Are there any tests, Professor?
As you know very well, in the NOAA trial, that was the neoadjuvant trial of Luca Gianni, there was a subset of patients receiving only dual blockade that achieved in 23% of the cases a pathological complete response. And those patients were patients without expression of estrogen receptor and progestinic receptor. In my opinion, this is a 73 years old, so I completely agree with my colleagues to give just paclitaxel and trastuzumab or eventually TCH, because if you use the dual blockade in a patient that is not so young, there is of course the risk of increasing cardiac failure risk. Of course, you should consider also if she has hypertension, if she is obese, or has any other risk factor like smoking. But I completely agree with the proposal of my previous colleagues. The best way to move here is paclitaxel plus trastuzumab or TCH without any use of anthracyclines.
Okay, so absolutely agreed, Professor. And the reason why we added pertuzumab was also because we wouldn't be able to use anthracyclines on this lady. TCH is something that our patients don't tolerate as well as the Caucasians. So we are sometimes concerned about using TCH in our elderly patients. So that was the reason why we decided to do nab-paclitaxel rather than conventional paclitaxel, considering her diabetic status. And of course, trastuzumab and pertuzumab. She, in spite of using nab-paclitaxel, had grade 3 skin reactions, grade 3 neutropenia. She started with weekly, and then we had to push it to 2 weekly at the same dose. A lot of problems, but somehow sailed through. God's sake, God willing, her ejection fraction maintained. Good clinical response after 12 weeks. So she had a right modified radical mastectomy done. And to our surprise and a pleasant surprise, she had a pathological complete response. Randeep, what would be your adjuvant therapy for this lady, Randeep? So we are not going to use any more anthracyclines considering the background issues. So would you do a dual therapy or would you do just trastuzumab considering her pathological complete response?
So we will consider for us trastuzumab and complete 1 year of duration. As you said, yes, no adjuvant chemotherapy further, as she has already given the proof of concept that she has tolerated weekly paclitaxel. I would like to take help from radiation oncologist, but would like to seek a referral for post-operative radiotherapy because it was a node positive disease to begin with.
Okay, so you would just continue
ERPR negative.
ERPR negative, correct. So you would just continue trastuzumab rather than doing dual anti-HER2 therapy. What about Sachin?
So I would agree with Randeep here for considering only trastuzumab as in the adjuvant therapy because of her good pathological response. But then we had started with a locally advanced disease with T4 and node positive. So considering only the oncological aspects, I may be tempted towards adding or continuing pertuzumab as well. But then that will all depend upon how she is clinically at the end of her neoadjuvant therapy and the end of her operation. So if she's absolutely fine, clinically stable, I may be tempted to continue with dual antibody therapy.
Absolutely. So she was absolutely fine, Sachin, and that's the reason, as you rightly pointed out, with a locally advanced disease to begin with, we were tempted to use trastuzumab, pertuzumab. Her cardiac status was good. So I think it was just after the was there somebody? Okay. So she was started on trastuzumab, pertuzumab again. She had one cycle. And then during the second cycle, this actually happened in the daycare. She had an acute myocardial infarction. This was while the trastuzumab infusion was actually going on. She was managed conservatively. There was nothing like an emergency angiogram or anything of that sort that was performed because the ejection fraction was reasonably okay, though she had congestive heart failure itself. Now, this is 6 weeks after the myocardial. The 2D echo is showing 55% ejection fraction. Earlier, it was 56% when we started her treatment. There was no regional wall motion abnormality when we started, but now she has mild hypokinesia of the apex. So the question is, should we continue anti-HER2 therapy because her ejection fraction is fine? Or should we cut down on the anti-HER2 therapy? Should we completely stop it because she's had a pathological complete response and these patients have an extremely good outcome? Professor, I think I'll have to fall back upon you because this patient is going to come next week and I have to answer this question. So I'm putting this question across to you. what would you do, Professor?
Zumab, she had a myocardial infarction. We should be aware that trastuzumab, because infarction may have a future evolution. So, in my opinion, since she has a pathological complete response, what we have to do is to stop treatment.
Excellent. So I'm glad, I also thought of the same thing, but, I was not confident enough to say that you can stop all your therapy since we started with the T4B. But now that you have endorsed my opinion, I'm so happy, Professor. Thank you so much for that opinion. So I think, considering the fact that patients with a pathological complete response have an excellent outcome, it may be perfectly all right to stop this lady's anti-HER2 therapy any further, even though her ejection fraction is reasonably okay with some regional wall motion abnormality. I put up this on the screen just to tell you that this doesn't talk about what happens if you have an acute myocardial infarction while on treatment and your ejection fraction still continues to be good. But as Professor rightly pointed out, it might be, that this is an early warning sign for things that are to come. So it's better that we look at these early warning signs and hold therapy rather than continue her anti-HER2 therapy. Ashish, Sachin, anybody has a difference of opinion on that? Would anybody be daring enough to continue at least trastuzumab or, anything of that sort?
Actually, there was a question in the chat box. If she would not have had pathological response, then what we would have done?
Excellent question, Professor. Professor, you have to answer that question also. What if she didn't have a pathological complete response? Would you have continued trastuzumab? Because we clearly know both will cause more problems.
So
Or
without a
TDM1.
myocardial, yes,
Or TDM.
without a myocardial infection, maybe you continue the treatment. Because as you know, from the German breast group, if you analyze the data of large tumor, like PT4, they may have a risk of recurrence, even if 73 years old. Diabetes, a myocardial infarction, so I believe it's enough.
Professor seems to be having some problem with his connection. So the point he was, at least from whatever I could make out of his connection. Professor, are you around? Are you able to connect? Okay, never mind. So there are so many questions in the chat box. If she didn't have a PCR after dual blockade, I think what we should do is to escalate to TDM1. But again, the question is the same with a recent cardiac event. Would you be happy to escalate to TDM1, keeping a close watch because this lady is likely to have a poor outcome? I think there's no one answer to that question. It becomes important to discuss this issue with your patient, explain the risks, and also talk to them about the fact that the likelihood of recurrence is going to be high without further therapy, and then go ahead with whatever after the discussion seems to be the most appropriate. So let's move on now to our next patient. So this
Dr. Senthil, can I just make a point here?
Quickly, Ashish?
Yeah, so just wanted to understand about with the panelists that safety of all the new anti-HER2 with a create clearance of less than 15 ml per minute is something.
I think there is no data, Ashish, but there is no data. But as you rightly pointed out, these are not drugs that are metabolized and excreted through the kidney, at least from whatever that's available. But there is no data in patients who have compromised renal function. I don't think there's a trial or even a small trial where these drugs have been used in this set of patients. Your point is very, very valid. Thanks, Ashish.
Yes, thank you.
Okay, we quickly move on. We've just got 15 minutes to go. 40-year-old lady with a left breast lump and bilateral axillary lymph nodes, no family history of breast cancer. She had a mammogram and an MRI that showed a left breast lump, bilateral axillary lymph nodes. There was no primary tumor in the right breast. You can see the PET CT scan showing the left breast lump, axillary lymph nodes, opposite axilla. Nothing picked up here on the right breast. The MRI also did not show anything in the right breast. So her diagnosis, after her pathology was a carcinoma of the left breast, clinical T2N1M1 because of the opposite axilla without a primary being detected in the right breast. The second element in the carcinoma was a squamous cell carcinoma. This was not a mesenchymal element. Grade 3 ERPR was negative. The HER2 was positive. H2 is not 2+, it's HER2 positive on both sides. Okay. She was also BRCA1 positive. So that is where we are. So she's got an opposite axillary lymph node that makes her M1. It's a metaplastic carcinoma. It's showing squamous elements. It's ERPR negative and a HER2 that is positive. It's the same ERPR HER2 expression on both the sides. I mean, when I say both, I'm talking about the right axilla and the left breast cancer. So the first question is, let me start from Dr. Chinoy. Madam, can metaplastic carcinomas be HER2 positive? Because typically our understanding is that it is triple negative. Madam, can you take that question?
There are instances where squamous carcinomas have expressed HER2, but they're clinically ER/PR negative and they AR positive. Many of them are androgen receptor positive. HER2.
Madam, is metaplastic also androgen positive, or is that androgen positive? Is that commonly androgen positive, ma'am?
Yes.
Okay.
So, Dr. Senthil, thanks, ma'am. Dr. Senthil, recently we've seen a upping number of metaplastic carcinomas coming HER2 positive. As you rightly said, that it's a not commonly documented phenomena. And we've seen at least, I think, 5 to 10 patients now where there are metaplastic carcinomas to upfront HER2 positive. And as the patient relapses, the HER2 disappears, then only the TNBC comes back.
Interesting.
So it's a very weird situation, and it's a very difficult for the medical oncologist. So I'm sorry, I just had to share this experience that it's not that it is not known, it's there, but they're
absolutely. That's why I asked this question, because I think it's important for us to realize that it is known to happen. That's the reason why I asked this question. Madam, Dr. Chinoy, can you quickly run us through in a minute what metaplastic carcinoma is?
Okay, it's a very heterogeneous group of tumors which are low grade and high grade. The low grades are the adenosquamous and the ones fibromatosis like squamous carcinoma, and the high grades basically are carcinomas, whether they show spindle or squamous, chondroid or osteoid. They are carcinomas. They will express keratins as their marker, and they are triple negative. But I also endorse what Tanuja said. We have squamous carcinomas which are HER2 positive also. So HER2 seems to be ambiguous. It straddles both sides.
Okay, excellent.
Okay.
So 2 components and typically triple negative, but can also sometimes express HER2. Sachin, intent of treatment, opposite side axilla, that's positive, palliative, curative, not too sure at this point in time. We'll decide on the go. What would you say, Sachin?
I'll go with curative intent.
You'll go with curative. Anybody on the panel wants to say no to Sachin? It's a metaplastic carcinoma, not one of those good prognosis ones. We're not talking about ER positive ones.
So basically three aspects if I want to defend my curative intent.
Yes. Sachin.
One is obviously young age. That is one.
Okay.
Second is opposite axillary lymph node involvement. Now there's a lot of debate being considered whether should we really be considering them as metastatic or they are considered as N3 disease. So there's lots of debate coming up with that.
All right.
Because the prognosis is still better than the true metastatic.
Agreed.
And third is HER2 positive metaplastic carcinomas. So HER2 positive metaplastic carcinomas may do better than the ones which we have conventionally metaplastic carcinomas who do not respond very well to chemotherapy. So because she is HER2 positive, I am expecting more with the anti-HER2 therapy and chemotherapy.
Lovely, Sachin. I think points very well made. Let me ask you, Sachin, if it was a triple negative metaplastic, would you have changed your thought process or you would have still pushed?
I would have still pushed with curative.
Okay. Excellent. Very good point. Very well taken. So we'll come to Sachin's point in a little while. He made a very important, interesting point saying that the prognosis of HER2 positive metaplastic carcinomas are much better than the typical run-of-the-mill metaplastic carcinomas that you would routinely see. Excellent. So, and second, Bharat, would the presence of squamous or mesenchymal elements impact your choice of chemotherapy? Now, our patient has got squamous. Let's say this was some chondroid differentiation that you saw somewhere. Would that change the way you manage this patient, Bharat?
So I have come across a couple of patients. And, it's a bad in the unusual histology. We always come across aggressive on one end and indolent or a dormant disease on the other end. When we know that this disease histology is bad and going to behave bad, unfortunately, all the cases, even though they were locally advanced, poor prognosis, poor response to the chemotherapy, recurred very fast. This is what I have seen. So if I'm planning with a curative intent, I have to discuss with the patient. This is unmet need. This is the area where no other newer approaches, molecular genomics, immunotherapy has to be explored. And you have to do because you are not going to get big numbers to have a clinical trials. So if it is triple negative or if it is HER2 positive, if it is HER2 positive, I will be very happy because I know there is something which will work. But if it's triple negative, I would also like to discuss the option of doing PDL1 or other markers where no experimental drug, which we know that if they have a good PDL1 expression, they do respond to immunotherapy. Couple of groups abroad have tried dual immunotherapies or combo of chemo immunotherapy in a metastatic setting. And to a certain extent, there were some responses which were better than the chemotherapy. For all those patients, 2 or 3 I have treated in the metaplastic or those chondroid, I followed a traditional chemotherapy approach for a breast cancer because there is no guideline. We follow for a neuroendocrine. You
okay. So the point is that you will just treat it like a triple negative cancer. That's the point, right, Bharat? Is that right?
Now, based on my personal experience in the past, I would like to take the newer drugs coming up.
So you're saying that if there is an opportunity to add an immune checkpoint inhibitor along with your chemotherapy, you would be more than happy to add that, correct?
Absolutely, yes.
Yes, and then let's not get into the murky story of the PDL1. Let's leave it at that. So again, our patient had trastuzumab, pertuzumab. The reason why we added carboplatin is looking at that squamous element. There was a lot of discussion, and then our tumor board we suggested that we should add carboplatin also here in addition to paclitaxel. So that's what happened for this patient. And she had a clinical and a metabolic CR after neoadjuvant chemotherapy. So she went through adriamycin, cyclophosphamide, dual anti-HER2 plus pacli-carbo weekly. And then she ended up having a pathological complete response. She underwent a bilateral axillary lymph nodal dissection. Ashish, radiation to the opposite side or no radiation?
So again, so it's a very controversial issue about on opposite side axilla, wherein there is only and you've got a path CR. But since she's a young patient again, and the intent of the treatment is curative, and one would opt for going for a axillary node radiation as well.
Okay, so you would want Randeep, you would want to do opposite axillary radiation. You would just leave it, Randeep, because dissection has been done.
I would leave it because we consider it as an oligomet. I would not like to add to morbidity because whatever said, it is a metastatic site. Unless, if you are considering a radiation there, that means you are considering it as the second primary, and then that we are not considering here.
Absolutely.
So, just to put it in context, that's why we will not give radiation to that.
Excellent. So axillary dissection was what we did. We didn't do radiation beyond that. So just to run through, because this is a rare subtype, I thought we should end with a summary. Metaplastic carcinoma contains 2 cellular subtypes, glandular and a non-glandular. And this non-glandular can be, a non-glandular epithelial element, which is usually squamous, or a mesenchymal element. They're usually locally advanced. They have lesser nodal burden, contrary to what I showed you now. P53 is altered, one of the reasons why they're very resistant to conventional approaches, and a high Ki67. Now, this is a statistic in case you want to know what percentage it is in terms of the phenotype. 64% was triple negative, 5.2% was HER2 positive, and a quarter were actually ER positive, something that at least I learned preparing for this. And of course, when we had this case and then we discussed this in our tumor boards, a quarter of them are actually ER positive. They are more aggressive than the classic triple negative breast cancer, treated similar to the non-metaplastic counterparts, which means you treat for what you would do if it's a triple negative or a HER2 positive or an ER positive breast cancer. The responses are extremely poor for a classic metaplastic carcinoma. Look at this, it's 12.5% response rates versus 75% for triple negative breast cancer. Nowhere, and there are hardly or no pathological complete responses compared to nearly 50% that you get for triple negative cancers. They are especially resistant to anthracycline, cyclophosphamide. As Sachin rightly pointed out, the HER2 positive subtype has the best outcomes. The overall survival is 91% at the end of 3 years for patients who are HER2 positive metaplastic, 75 for the triple negative metaplastic, 77 for the ER positive metaplastic. So the HER2 positive one seems to be a little distinct compared to the other metaplastic carcinoma. So let's not go away with the impression that this is always triple negative and always has poor outcomes. If it's a classic metaplastic, obviously the outcome is likely to be poor. So that's something that one needs to know. So this is a recent paper from the JAMA Oncology. Nearly 8,000 patients. That this is medullary carcinoma, this is adenoid cystic carcinoma, and this is metaplastic carcinoma. The gray bar is the I'm sorry, the ERBB positive. So without going into the details and wasting time, what I want to tell you is that it could be all of these receptor positive types. The orange is the medullary one, which has the best outcome. The next one is the adenoid cystic, and metaplastic carcinoma has the worst outcomes among all of them. So this is something that we, at least we don't routinely discuss in all our meetings. The genomic landscape is very different. Jyoti, we have 5 minutes. Can I do that? The last case?
Okay, quickly.
Okay, 5 minutes. We'll quickly run through this. And so this was another interesting histology. 45-year-old male. Remember, this is not a female. This is a male with breast cancer. No comorbidities, left axillary mass of 18 months. No pain, ulceration, or systemic symptoms. I'm talking about pain and ulceration over the lump, obviously. On examination, a 5 centimeter mass in the anterior axillary fold, few lymph nodes, 2 centimeter, no skin ulceration, tethering, or puckering. A biopsy elsewhere was invasive carcinoma with apocrine features. The IHC done outside was ERPR negative. The GATA3 was positive. The HER was 3+. Ki67 was more than 50%. An ultrasound showed multiple well-defined lobular discrete conglomerate lesions in the left axilla. Largest was 33 millimeters. So it's left axillary lymph nodes plus minus a tail mass. A block review that was done at our hospital showed invasive carcinoma, grade 2 with oncocytic features. Query apocrine carcinoma from the axillary tail / skin adnexa. Node parenchyma is not seen. The IHC was ERPR negative. The HER2 was 2+. A FISH was done, which was negative. The GATA3 was positive. The GCDFE was focal positive. Chromogranin was negative. The AR was positive. Okay. Let me stop at this point. Dr. Chinoy, would you agree with the diagnosis of an apocrine carcinoma, or based on the morphology that is described here? I just transcribed what was there in the pathology report and the immunohistochemistry. What would be your diagnosis, Dr. Chinoy?
Yeah, I would agree that this has it's a infiltrating breast cancer. Large pink cells, it's reported as oncocytic features, and it fits the bill. It's ERPR negative, and HER2 is known to be positive, GATA3, and this is the one where androgens come.
Right. So you are happy with the diagnosis of apocrine carcinoma, at least invasive carcinoma, with at least some apocrine differentiation, at least at this point in time, based on the morphology described here and the immunohistochemistry. PET CT showed multiple left axillary nodes. The largest was 2.5 into 2 centimeter. No distant metastasis. So left breast axillary tail, at least based on the imaging and clinical features, T2N1 M0 triple negative here. Surgery or neoadjuvant chemotherapy, considering the fact that it's, there's a likelihood that this is an apocrine carcinoma. Bharat?
So again,
surgery or neoadjuvant therapy here.
Yeah. So this rare histology again, one odd patient I have seen, they don't respond, but they are indolent disease. So here, rather than introducing chemotherapy as a first-line therapy, I would like to send the patient, if resectable, for surgery.
Excellent. Randeep?
I agree with Bharat. We don't have the guidelines. If someone wants to treat it like a classical ERPR negative, that is also fine, but I would like to refer and then consider adjuvant therapy definitely.
Ashish, would you also agree?
Yes, I agree with that. Because it's certainly negative, so we go ahead with surgery.
Excellent. So since apocrine features are mentioned there and we are not too sure about the real nature of the triple negativeness in this situation, we also, after a lot of discussion, decided to send this patient for surgery. So this patient underwent a left axillary lymph nodal dissection. So the mass along with the lymph nodes came out. And here is the pathology report. I won't go into the details. Dr. Chinoy has already described that in part because I sent this report, to all of you. So the final diagnosis is an apocrine carcinoma of query the left axillary tail plus lymph nodes or in the lymph nodes. So what would you do, Sachin, as adjuvant therapy for this patient? This is apocrine carcinoma.
So even though it's an unusual or uncommon histology, biologically they would behave the same, or maybe they will have a better outcome. So I treat on the same lines as that of any other breast cancer. So I'll offer the same standard adjuvant therapy with anthracyclines and taxanes. So the standard as like other IDCs.
Okay, Randeep, any difference?
Dr. Senthil?
Yeah, please, madam.
Dr.
Please go ahead.
Senthil?
Yes.
See, actually, I think we missed the boat here.
Okay.
This is a skin adnexal apocrine carcinoma. It's a male patient, right?
Yes.
So this is a rather, it's a rare but seen situation in oncology. And actually, it's a skin adnexal cancer. Because if you look at the first report, if you remember the first report, it said skin.
Yeah, they suggested that. They suggested that.
Correct. So there is no IHC that will help you differentiate between a primary breast apocrine versus a skin apocrine.
Correct.
But this is a typically described situation in the axilla. So if you have a male breast and an apocrine tumor, you don't treat it like a breast cancer, like a skin adnexal apocrine carcinoma.
Okay.
So if that situation comes in, I'm not sure what chemo there is then, but these
there isn't.
There is no chemo.
There isn't.
So and they behave rather indolently.
Absolutely.
They would, I remember 20 years back, the first case I saw, we treated him like a breast. Nothing happened to the tumor. He continued to live for 5 years. I think he continued with the nodal. He kept having nodal metastasis. So that's my one case, and we get it very frequently now. I mean, it's a rare. I'm not saying it's an everyday problem, but it does occur.
Yes.
So chemo will give for our satisfaction and patient satisfaction.
Correct. So you're absolutely right, madam. So there was a lot of discussion with the pathologist. We went back, reviewed the clinical features, this, that, but ultimately we were never able to come to a conclusion as to where it all started. So there was a lot of discussion with the patient. He's a 45-year-old guy. We did speak a lot about apocrine, its features, and so on and so forth. And beyond that, he said he went and took a couple of second opinions here and there. Everybody said it's triple negative. Let's go and treat. So we actually, are doing some chemotherapy for this patient. Though every single point that you made is absolutely correct, and what Sachin said is also correct. So since we were not able to clearly say what this is, whether it's a skin adnexal, you have your absolutely right reason to say that it might be a skin adnexal tumor. But, we were never able to clearly conclude what it is. So I left it at that point. And then, this is what we did. Right, wrong, I think is a difficult question to answer. But this is what we finally did for this patient. So quickly run through this and then I'll stop, Jyoti. Apocrine carcinoma is clinically, morphologically, and molecularly different from triple negative, though the receptor phenotype is usually of triple negative. The pure apocrine carcinoma is greater than 90% cells showing those apocrine morphology features. ERPR negative, AR is positive. That's something that's very typical. This can also be HER2 enriched, right? So if you do a PAM50, you can find that some of them are actually HER2 enriched, 1% of all breast cancers. But remember that some of them can actually some of them can actually have apocrine differentiation. So that's treated typically like a triple negative breast cancer. Elderly, lower stage, less aggressive, as everybody has pointed out. The behavior is very ambiguous. That's what the literature says. There's no standard recommendation for treatment. It's treated like TNBC or a HER2 positive cancer, depending upon what what you find out on the receptor status. This is to show you the genetic landscape. A lot of them are PIK3CA, PTEN, and TP53 mutated. So hopefully AR targeted therapy or one of these targeted therapies will help us in the future to manage this patient. Localized ones have excellent outcomes. They probably don't need any adjuvant therapy at all. But as Sachin said, there's always that doubt at the back of our mind as to what is to be done. And then the younger your patient, you tend to do some chemotherapy, and that's what is going on in our patient. Jyoti, thank you so much. I have one more patient, but I will not, take your time and delay the program. Thanks so much for that opportunity. And